Hello again, everyone. This video will be discussing the different types of myeloproliferative neoplasms. Myeloproliferative neoplasm is previously known as myeloproliferative disease or myeloproliferative disorder. To understand the general concept of MPN, we simply have to dissect the words. Myelo means from the bone marrow, proliferative means an increase in the number and a rapid spread. Neoplasm means new growth, and in this case, we are referring to the growth of tumors or cancer cells. Putting all these together, we can now say that myeloproliferative neoplasms are clonal hematopoietic disorders caused by the genetic mutations in the bone marrow stem cells that will result in the proliferation or the expansion or the excessive production and accumulation of abnormal cells. MPNs are a rare group of blood cancers. That is one reason why the name was changed from disorder into a neoplasm so that it reflects the underlying clonal genetic changes that happens with the disorders in the group. What happens is the hematopoietic stem cell undergoes mutation that leads to the excessive production of the different cells. It can be an excessive growth of red blood cells, white blood cells, and or platelets. Since the bone marrow stem cells are the ones primarily affected, any of the resulting cell lines may be affected as well. For example, if a proliferation of erythrocytes is seen, this type of MPN is known as polycythemia vera. If, for example, the neutrophils are the ones proliferating, then this MPN may be called as chronic myeloid leukemia. The World Health Organization has classified MPNs into four predominant disorders. We have chronic myelogenous leukemia or CML, polycythemia vera or PV, essential thrombocythemia or ET, and primary myelofibrosis or PMF. Several other less common MPN conditions have also been described and are classified as chronic neutrophilic leukemia or CNL, chronic eosinophilic leukemia or CEL, mastocytosis, and other myeloproliferative disorders that are unclassified. This video will talk about chronic myelogenous leukemia, essential thrombocythemia, and chronic neutrophilic leukemia. Chronic myelogenous leukemia is also known as chronic myeloid leukemia or chronic myelocytic leukemia. This is a type of cancer that concerns white blood cells. This leads to the increased growth of predominantly myeloid cells in the bone marrow, myeloid cells, that's why the name myelogenous is given, and leads to its accumulation in the blood. Specifically, which cells are accumulated? These are the mature granulocytes, neutrophils, eosinophils, and basophils, including their precursor cells. Chronic myelogenous leukemia occurs in all ages but is seen predominantly in those aged 46 to 53 years. The term chronic signifies that this is a disease of the adults because it takes time for CML to develop and to manifest. It represents about 20% of all cases of leukemia and is slightly more common in males than in females. The genetic mutation or abnormality that involves CML is a unique chromosome called as the Philadelphia chromosome. The Philadelphia chromosome is a reciprocal translocation between the long arms of chromosome 9 and chromosome 22. The translocation of chromosome 9 and 22 forms the BCR-ABL protein, which is responsible for activation of cell division. The two chromosomes involved in chronic myelogenous leukemia are chromosome 9 and chromosome 22. The ABL gene from chromosome 9 transfers to the BCR region of chromosome 22. This translocation results in a new chromosome, which we now call as the Philadelphia chromosome. Let's be a little bit more specific. So the ABL proto-oncogene from band 34 of chromosome 9 transfers to the breakpoint cluster region, band 11 of chromosome 22, resulting in a unique chimeric gene, which is the BCR-ABL1 gene. This new gene produces the BCR-ABL fusion protein, which expresses an enhanced tyrosine kinase activity compared with its natural enzymatic counterparts. Although the cause of Philadelphia chromosome formation is unknown, it appears more frequently in populations exposed to ionizing radiation. An example is that the individuals exposed to the Hiroshima and Nagasaki nuclear bombing had a 50-fold increase of developing CML. Chronic myelogenous leukemia has three phases. The first one is the chronic phase, followed by the accelerated phase, and the last phase is known as the blast crisis. The chronic phase takes around 3 to 5 years to progress and to develop. Patients in this phase may be asymptomatic or they may experience mild symptoms. If this is left untreated, it may progress to the next phase, which is the accelerated phase. This phase may be diagnosed when less than 10% of blasts are seen in the peripheral blood and the bone marrow. Before blastic transformation, some patients proceed through an intermediate metamorphosis or accelerated phase. This is the phase where it is a significant marker that the disease is about to progress to the last stage. The circulating blast count increases to 10 to 19%. This total blast percentage, or a combination of 20% blast and promyelocyte, are the proposed diagnostic criterion for the accelerated phase. Additional chromosome abnormalities may also be detected. In this phase, splenomegaly and an increase in white blood cell count is seen. Patients may also be unresponsive to therapy. This phase may only take around 6 to 9 months to progress. Blast crisis is the final phase of chronic myelogenous leukemia. The clinical symptoms of blast crisis mimic those of acute leukemia, where there is rapid progression of around 3 to 6 months and a short survival rate. The blast crisis involves the peripheral blood, bone marrow, and extramedullary tissues. Based on acute leukemia definitions, blasts constitute more than 20% of the total bone marrow cellularity and peripheral blood. Extramedullary growth may be seen or may occur as lymphocytic or myelogenous cell proliferations. The latter are often referred to as granulocytic sarcoma or chloroma. Chloroma is a rare malignant tumor made up of granulocyte precursor cells. The development of chloroma is the focus of leukemia when it is outside the bone marrow. Peripheral blood smear also shows or exhibits increased blast forms. Signs and symptoms of chronic myelogenous leukemia will depend on the stage of the disease where the patient is on. General signs and symptoms would include fatigue, easy bruising or the formation of purpura, fever, and some splenic enlargement. For laboratory diagnosis, in the peripheral blood, approximately 15% of patients exhibit total white blood cell counts greater than 300. An increase in granulocytes, the neutrophils, eosinophils, and basophils are also seen. Platelet count is often increased, reflecting the myeloproliferative nature of the disease. Initial testing for LAP, or leukocyte alkaline phosphatase enzyme activity, may be useful in setting the preliminary differentiation between CML and leukemoid reaction. LAP in CML is decreased. In the bone marrow, the presence of pseudo-Gaucher cells, which are these cells, usually occurs. Diagnosis of CML is confirmed by demonstrating the presence of the BCR-ABL1 fusion gene using the fluorescence in situ hybridization, or by detecting the BCR-ABL1 fusion transcript by qualitative reverse transcriptase polymerase chain reaction. For CML treatment, bone marrow and stem cell transplantation with either autologous or allogenic hematopoietic stem cells have been reported as curative, especially in patients younger than the age of 55. Modern therapies involve the use of synthetic proteins that bind the abnormal BCR-ABL protein, reducing signal transduction activity. Splenectomy may be done to alleviate signs and symptoms. Imatinib has been proven to be a successful form of therapy. Major limitation is the development of imatinib resistance during relapse. The second MPN to be discussed is essential thrombocythemia, or ET. Over the years, ET has been known as primary thrombocytosis, idiopathic thrombocytosis, and hemorrhagic thrombocythemia. Essential thrombocythemia is described to have a sustained megakaryocyte proliferation that leads to the increase in the platelets that are circulating in the peripheral blood. Essential thrombocythemia is a clonal MPN with increased megakaryopoiesis and thrombocytosis, usually with platelet counts more than 600. Sometimes platelet counts may even reach up to more than 1,000. However, the World Health Organization criteria requires that there should be a sustained thrombocytosis with platelet count of 450 or greater before being diagnosed as essential thrombocythemia. The majority of cases occur in individuals between the ages of 50 and 60 years. But a second peak occurs primarily in women in the childbearing years, approximately 30 years of age. ET incidence in children is very low. Patients with essential thrombocythemia may carry the JAK2 mutation, the MPL mutation, the CALR mutation, and as well as other several minor mutations. The JAK2 V617F mutation is seen approximately in 55% of patients with ET. JAK2 mutation may also be seen in other MPNs like polycythemia vera and primary myelofibrosis. MPL mutation are observed in 3% of ET patients. JAK2 and MPL mutations are known as the driver mutations for MPN. Most ET patients who do not have the JAK2 mutation will have the CALR mutation of the CALR gene. This gene provides instructions for making the multifunctional protein called calreticulin. Calreticulin is involved in a variety of intracellular, cell surface, and extracellular functions like quality control, production of MHC class I, and transcription regulation. The CALR mutations found in patients were either small insertions or deletions in the narrow region of the exon 9 of the CALR gene. 52 base deletion and 5 base insertion account for approximately 80% of all CALR mutations. More than 50 types of CALR mutations have been reported so far, but all of them are small deletions and insertions. With the CALR mutation, a signaling pathway is stimulated, and this transmits chemicals to signal cell proliferation and oncogenesis. The mutant CALR interacts with the MPL gene that activates the downstream signaling of molecules responsible for the growth and division of cells. MPL is the Myeloproliferative Leukemia gene, which provides the instructions for making megakaryocytes. This would increase the proliferation of megakaryocytes, also increasing the number of platelets since one megakaryocyte can produce numerous platelets. This picture can also explain why when a mutation in the JAK2 region or JAK2 gene and a mutation in the MPL gene can also increase proliferation of cells. The signs and symptoms for essential thrombocytosis usually include headache, dizziness or lightheadedness, visual disturbances, coldness or blueness of fingers and toes, and enlargement of the spleen. The burning feeling with redness and pain in the hands and feet is usually called vascular occlusions and is often the result of microvascular thrombosis. Thrombosis happens because of the increased platelet in the circulation. The newest World Health Organization group now requires the documentation of 4 major criteria to establish a diagnosis of essential thrombocythemia. The World Health Organization needs a platelet count threshold of 450 or greater. That means the platelet count should be increased. Second, the bone marrow must show significant megakaryopoiesis characterized by large, mature-looking megakaryocytes with no substantial or normal erythropoiesis and normal granulopoiesis. That means only the megakaryocytes or the platelets in the bone marrow are increased. Third, the condition cannot meet the criteria of any other MPN. That means ET is diagnosed by the process of elimination. You have to consider other MPNs first before considering ET. Fourth, the patients must demonstrate the JAK2 mutation or other clonal mutations. In the presence of all of these 4 criteria, then the diagnosis of ET may be established. The median survival for patients with essential thrombocythemia is 20 years, giving it a long survival rate. Treatment involves the prevention or early alleviation of hemorrhagic or vaso-occlusive complications that occur because of the increase in platelets. Therefore, the production of platelets must be reduced by suppressing the marrow megakaryocyte production with alkylating agents like hydroxyurea. Let's now proceed to the other or the minor classes of MPNs. Although 4 minor MPNs have been noted, we will only be talking about chronic neutrophilic leukemia. Chronic neutrophilic leukemia is a clonal disorder in which a hyperproliferation of neutrophilic cells in the bone marrow produces a sustained neutrophilia in the peripheral blood. Chronic neutrophilic leukemia must be differentiated from chronic myelogenous leukemia. The Philadelphia chromosome or the BCR-ABL mutation cannot be expressed in chronic neutrophilic leukemia. If the Philadelphia chromosome is present, that means a diagnosis of CML or chronic myelogenous leukemia is required. Chronic neutrophilic leukemia is also the rarest of the chronic myeloproliferative neoplasms. For signs and symptoms of chronic neutrophilic leukemia, hepatosplenomegaly is the most common finding, but 25% to 30% of patients report bleeding from mucocutaneous sites like the gastrointestinal tract. Other symptoms would include gout from WBC turnover, and pruritus that may be associated with neutrophil infiltration of tissues. Let's start with the clinical findings in the bone marrow. The bone marrow is hypercellular with predominantly the proliferation of neutrophils. The myeloid to erythroid ratio is at least 20:1. In the peripheral blood smear, patients have a white blood cell count of more than 25, but may be as high as 100. Neutrophils do not appear dysplastic, but they often contain toxic granules and a few DOLA bodies. Red blood cells and platelet morphology are normal. For other tests, the lab scores are extremely high, ranging from 350 to 400. Another finding is that the B12 levels frequently are markedly elevated. Chronic neutrophilic leukemia is a slow developing condition which may take 6 months to 20 years, but CNL may develop into another myelodysplastic type, or it might develop into acute myeloid leukemia. And that ends this video about myeloproliferative neoplasms. Make sure to watch the other two videos about the introduction to white blood cell disorders and the non-malignant leukocyte disorders video. Thank you for watching.